What I'm going to do today is tell a story. It's really the story of our work here at UAB and its impact on Alabama and the Deep South. It was in the early 90s that I decided that I had given up on doctors. So doctors were hard to change their behavior. So I decided that I would bypass the physicians by going into the lay community and training them to deliver components of health care. So I'll talk a little bit about cancer disparities, our experience over the years in reducing and eliminating the disparities, and then how that's morphed into a spin-off company called Guideway Care. I'm the chief medical officer of that, so I need to disclose that at this point in time. It's a spin-off company from the program that we did here at UAB toward the end of my career. So if you go to 90, that's when I first came back to the university out of private practice to direct the division of GYN oncology. Something was emerging in the country that we had not seen previously, and that was disparities between the white and the African American population. If you look back here, in the early 80s, mortality was equal. What happened? School of Public Health? What happened? Why did this happen? And just to reinforce it, it happened with colorectal cancer also. If you look back in the 70s, no difference in females, males, white and black, but then you begin to see disparities. John, don't say it.
Somebody take a risk. No penalty for a wrong answer.
What? Surveillance, right. So mammography and colorectal screening were developed in the 70s. So prior to that, we didn't have a way to really screen for breast and colorectal cancer. And other thing that occurred in the 70s and 80s was we actually got effective treatment for both of the diseases. But what happened? So we had some discoveries: mammography, colorectal cancer screening, treatment for breast cancer, treatment for colorectal cancer.
But for whom?
That's a clue. We delivered it differentially. So if you had an education, you had an income, you had insurance, you got a pap smear, you got age-appropriate colorectal screening, and if you had cancer, you got treated in a high-quality center. If you had less education, less income, no insurance, you didn't get screened, you were diagnosed with advanced cancer, and you might be treated in a less than adequate facility. There was one cancer in the 70s that had already had a disparity emerge. Which one was that? 60s and 70s, we already saw a disparity. Which cancer? What's the first cancer screen we had in the United States? Women.
Is that over here?
Cervical, yeah, cervical cancer. So there was a disparity in cervical cancer back in the 60s, but that was the only one that we had it in. So we made a conscious decision in the Cancer Prevention and Control Program, and John Waterboy was there at that particular retreat about 1992.
I remember it well.
When we said, we are an NCI-designated comprehensive cancer center in the Deep South. We're seeing these emerging disparities. We should focus our program on that. So we did that, but then the question was what to do. What were we going to do about it? And if you looked at the demographics, there we are right in the heart of this crescent of African Americans that were showing a disparate outcome for cancer. So this map actually was very useful to us in our grant applications, because when that went to the NCI, I think, just having that was helpful to us in terms of being able to get our grants funded. So what I'm going to do here is tell a story of using non-clinical deliverers of healthcare across the cancer continuum: prevention, early detection, treatment, survivorship, and end of life. Because we've actually worked across all of the areas. We decided to focus on two areas that we knew had high African American percentage population and a reasonable amount of poverty. So the Delta of Mississippi, the Black Belt of Alabama, inner city Birmingham, inner city Hattiesburg, and Laurel, Mississippi. Now I always thought the Mississippi Delta was down here, where the Mississippi River emptied into the Gulf of Mexico, but it's actually this stretch of land up in the corner with the Mississippi River on one side and the Yazoo River on the other side. And I think I've got the demographics. Demographics are 65% African American in both areas and 30% under poverty. So our first funded program to actually begin to address the issue was the Deep South Network for Cancer Control. We'd done a lot of things in the decade before this, mostly unfunded volunteer type of activities where we brought groups together that were interested in cancer control in the underserved populations. We actually went out and recruited 883, mostly African American women, some men, some white, but mostly African American women. They had an 8-week course, 2 hours per week, around cancer education, leadership skills, and how to communicate. And then after the program was underway, they had monthly meetings, maintenance meetings. And their goal was to promote breast and cervical cancer screening in their populations, the populations where they lived. They got a small stipend for the work they did. They were volunteer otherwise. And this is the results. So before the program started, there was a disparity of 16% between whites and African Americans. And in fairly short order, we increased significantly the African American participation in the Medicare mammography program. So this is Medicare data. So remember, everybody that has Medicare has insurance, but there was still a pretty significant gap in actually getting your mammogram. And with our educational process, that was eliminated. We also did something interesting in this small county in the Delta of Mississippi around cervical cancer screening. You see dark purple is a high mortality rate from cervical cancer. So we actually trained a group of community health workers. Community health advisors is what we call them, to go door to door in 2 small communities in LaFleur County, Mississippi, knock on the door, house to house, identify any females in the house, and determine whether or not they had had a pap smear ever or within the last 5 years. And then they were offered, if they had not had a pap smear, they were offered a pap test at the clinic, so going to the public health department, or a self-test to do at home. And we had already proven in a program before this that a self-test was equal to a provider-generated test with very little difference. So, not surprisingly, most of the women chose the self-test because they knew getting to the clinic was difficult. It had already been difficult. That was part of the reason they had their PAP in a period of time. And then completion, so of the 42 that said, I'll go to the clinic, only 40 did, 40%. And of the 77 that said they do the self-test, 62 actually did it for an 80% completion rate. Isabel Scarenzi, who's in the Division of Preventive Health, did the same kind of study in Brazil where she used paid community health workers that are part of the public health system there to go door to door identifying unscreened women. And in her self-test group, 100% compliance in 411 women. So it works, and that's good to know for those really hard to reach populations across the world, actually, not just here, but not surprisingly, when we start screening women who had previously been unscreened for either cervix or breast cancer, we found women with the cancer. And think about it, these are rural women that are under-resourced, so low income, low education, have to go to an urban area to get their treatment. So we thought, well, let's take a group of our community health advisors that have been promoting early detection and train them to actually navigate a patient in a rural area to an urban area to get her diagnostic and treatment, to meet her diagnostic and treatment recommendations, building on what we had already done. So we actually got them to 93% of 1,384 scheduled diagnostic or therapeutic appointments. We did worse in Jefferson County. We did much better in Dallas, Montgomery, and Sumter, the rural areas. And I think part of that was the women who had cancer actually knew the navigators because they were coming from small towns and knew the navigator because you kind of know everybody in small towns. And in the Jefferson County area, they didn't really know them. But 93 overall, 95, 96, 98 in the rural areas, which, was pretty spectacular. So, and then in 2005, we got dinged by the NCI, National Cancer Institute, at their site visit because we were accruing 11% of African Americans to our clinical trials, but they represented 20% of our population. So we were under accruing. And so what we decided to do is to train these 4 ladies, which you may have seen around the hospital, to meet every African American with a newly diagnosed cancer, talk about the pros and cons of clinical trial participation. They would then go to the physician. If they were eligible for the trial, they came back to the clinical trial navigator to see what barriers they had to participation in the work, in the clinical trial. Transportation, finances, insurance, babysitting. And the navigator would help them overcome the barrier, and you can see the results. So we doubled our accrual and actually were over accruing African Americans to clinical trials. And this is, to my knowledge, the only program that's ever worked in increasing African American participation in clinical trials. There are a lot of other things that have been tried, a lot of money spent on educational material and so forth, but you basically, talking to a group of people that don't have cancer yet, and it's just going in one ear and out the other. It's not real until you really have cancer. Now you've got somebody focused on you and the reason you might want to participate. So in about a 20-year period of time, we had shown that you could take community health advisors, many of whom, at least in the promotion of breast and cervical cancer screening, didn't even have a high school education. But you could take them and you could promote awareness, change behavior, increase screening participation. You could assist with compliance to diagnostic and treatment recommendations. You could increase minority participation in clinical trials. And they even effectively served as research assistants. I didn't show you the study, but Monica Baskins did a weight loss study in the Black Belt and the Delta, and she used community health advisors to serve as her research assistants. And the results of her program were equal to what you would find in the same kind of program in an academic medical center. So that brings us up to 2011. We started this work really about 1995. And as part of the Affordable Care Act, the Centers for Medicare and Medicaid Innovation was established, and they sent out an RFP, request for proposals, for any kind of program that you could design that would deliver better health care at a lower cost. So we had been working in prevention, early detection, and the early part of treatment. So we decided that we could take the same model that we had used for 20 years, recruit and train non-social worker, non-nurses, assign them to a Medicare patient with cancer in our 12-hospital cancer community network, and that those navigators would provide better health care at a lower cost. So we worked at UAB and 11 of our community cancer center partners across the Southeast. I want you to focus right here. I need to redo this slide. But this is a comparison of navigated patients to non-navigated controls. And what you see here is if you were navigated, you cost Medicare about $800 less per quarter. Per quarter. So these are quarterly looks. And the reason for that reduction in cost is you had a 6% reduction in ER visits, an 8% reduction in hospitalizations, and a 10% difference in ICU admissions, navigated versus non-navigated. Across the network, that translated to $19 million a year in savings to Medicare. $57 million across the 3 years. Medicare had an independent evaluation of the programs that they funded. They funded about 107 programs under this mechanism. 7 of them were in cancer. So they got NORC out of University of Chicago. And what NORC did is they compared our navigated patients to unnavigated patients at Vanderbilt and MD Anderson as part of their network in the last 180 days of life. So they look at death, go back 180 days, see what the spend was between navigated and non-navigated patients. And what you see is a significant reduction in 30-day, 90-day, and 180-day. This is actually per patient. So $8,000 less per navigated patient than non-navigated in the last 180 days of life. And again, it's ED visits and hospitalizations and reduction in chemotherapy in the last 2 weeks of life and more hospice utilization. That transmitted to $17 million across the network. So pretty successful. This is published in JAMA Oncology, 2017. Rock was the primary author, and this particular one is in Health Outcomes with one of the NORC individuals taking the lead. So given this data, what would you do at this point in time if you were UAB?
Do it.
Just do it, exactly. Just do it. So there are several things that are emerging that really, I think, point to the importance of navigation. And I'm going to stop and we'll a few more slides and then we'll talk. You've got a program that shows that lay navigators, non-nurse navigators, are effective in reducing cost. Now, what happens? Navigators 25 years ago were addressing cancer disparities. What causes cancer disparities? We've talked about it. It's something that we now call the social determinants of health, right? So the difference, again, in those outcomes were based on education, income, insurance status, and you could go down to where you live, how much social capital you have, what kind of food desert you're in, all of those other things that we know. So what navigators are doing is not rocket science. It is not rocket science, yet it's saving millions of dollars. What are they doing? What do you think they're assigned to do? Do they make clinical decisions?
I hope not.
Right. They're not making clinical decisions. They're making non-clinical decisions. What are they addressing? Social determinants of health. So, Ms. Jones, do you have a ride for your appointment next Wednesday? Did you get your prescription filled? Are you taking the medicine like you're instructed to take it? Do you have any financial problems? Do you have any psychosocial problems that we can help you with? Where do you live? Do you have a husband? Do you have another caregiver? What is your caregiver circle? Do a distress assessment. Navigators do a distress assessment every time they have an encounter with the patient, or at least monthly, to see where the areas of stress are and try to address those so that they can be compliant with their recommended treatment and that they can that they have the ability to get to their treatment and that they understand what they're supposed to do. So you know you have cancer, you go to the doctor's office, they tell you how you're going to be treated, you come out, and it's all a blur. You know, you've forgotten everything they've said. So navigators can help you with that process, and in helping with that, they reduce these unnecessary ER visits, hospitalizations, ICU visits. John.
The helping with the logistics certainly important, like do you have a ride and that sort of thing. I wonder how much of it, in addition, is someone caring about them and asking the questions. Even if I do have a ride and all that, if there's a navigator, another human being making a connection, saying,
Right.
I know you need treatment, I know blah, blah, blah. I
Yeah.
think that probably is a
Yes.
big motivator
There's-
for the patient to pursue getting the treatment rather than throwing in the towel and.
Right. There's no question, patient satisfaction is out the roof, and you get all kind of anecdotal stories about, this is the first time I've ever felt like UAB cared about me or somebody cared about me. No question about that. So what UAB decided to do was we actually spun off the company because we knew the program, because we knew health systems were going to be interested in having their own navigators given the fact that it's been shown to be very effective, number one, and number two, we're moving from a fee-for-service based healthcare delivery system to a value-based healthcare delivery system. So we're moving to bundles. So for chronic obstructive pulmonary disease, you get a set amount of money. If you can deliver the care in the first 90 days for less than that set amount of money, then you make a profit. If you go over, then you got to go to the bank and borrow it. We also are seeing a lot of Medicare shared savings programs. UAB is participating one in primary care, where if you reduce the cost to a population, you get to share in that reduction. We're participating in the oncology care model here, which is a model in which Medicare, again, will share savings in an oncology patient on chemotherapy if you can reduce the cost. And we've actually gotten shared savings from those programs. We saw some data on the COPD bundle that we're navigating, and we're seeing definite increases in patients that are costing less than the bundle itself. So it went from 48% to 70% that are actually below the bundle. So Guideway Care, Inc. is the company that has spun off from the UAB program. And this is what we try to do, is improve the patient experience, reduce cost of care, unnecessary utilization. We think we can, we don't know this for sure, but we think we can reduce provider burnout and get people working back at the top of their license. Now, the classic navigator in the United States today is a nurse navigator. So it's an RN, typically an RN that has about 20 years of experience, because the thought was the more experience they had, the better they would be able to navigate the patient. But as we've gone around the country and talked to them, about 70% of what they do is non-clinical. So they're working on all these social determinants of health well below their license, and they actually get a little frustrated that they're having to deal with that. And we do it by identifying and addressing the barriers to patient care, social determinants of health, increase patient compliance, integrate into the non-clinical staff, and we have really impressive information technology now, IT, that allows the navigators to really manage a large group of patients. This is what we've known intuitively for a long time, but now actually beginning to put it down on paper. So this is a Kaiser Foundation report, and you look at health and well-being. So 10% is health care, what happens in the walls of the clinic or the hospital. 30% genetics, 60% is the social environmental factors and behavior. So it's what happens outside the walls of the clinic. And that's why a school of public health is going to be even more important in the future, because you do your work, for the most part, outside the walls of the clinic. So the missed opportunity is there are two things that contribute to health spending. One is what you do in the walls of the hospital and clinic. Other is patient decision-making and compliance with the care protocols, with the recommendations that they've been given. So we use all kind of things on that left-hand side: clinical protocols, decision trees, evidence-based medicine, pre-authorizations, etc. And, nurses and social workers definitely can impact behavioral change. To some degree, they were trained to do that. But they are relatively expensive, and so being able to ramp up enough nurse navigators to take care of the emerging problem and our recognition of the importance of social determinants is going to be really difficult. So it's really an action gap phenomenon. So you got all kinds of information about the patient that comes out of EMR and other things. Clinical instruction compliance, patient engagement, education, medication adherence, etc. But the key piece, at least in our mind, based on the work that we've done over a decade, is guidance in managing those social determinants of health. So a care guide is financially sustainable because they are considerably less expensive than a nurse, and they can impact behavioral change in a community setting at home. Just by, for instance, it's something as simple as Miss Jones has gone to the emergency room with a problem with cancer. We find out the next day that she's been in the emergency room. We call her, we ask her why she went to the emergency room last night. Did she call the clinic or the office first? Did she know there was an urgent care center close to her home? And we begin to sort of change behavior by every time she shows up in the emergency room unexpected, we're asking her the questions about why she did it and trying to reinforce behavior to call the clinic first, call the office, or go to an urgent care center. So we're not only using artificial intelligence to determine risk, but we actually have a person assigned to each one of the people that we're taking care of. We have about 1,000 disease-specific protocols now that manage the social determinants of health. We use a non-clinical staff for non-clinical issues that frees up the clinical staff to take care of clinical issues. So care guides, care guidance protocols that keep them in their swim lanes. So we try very, very hard to make sure that they know what to do first, what to do next, and what to do last, and when to bump it up to the clinical team of which they're part of. It's really a redesign of the healthcare delivery, of the healthcare delivery team. So we've always had an MD. In the last 30 years, we've come up with the concept of the advanced practitioner. When I was in medical school, that idea had just started. We've always had nurses. Now we're adding another layer because we know how important the social determinants of health are, and that's called the care guide. And then that team obviously always needs a little administrative clinical help. So tasks are pushed down to the most appropriate provider. So if the patient needs surgery, the only person in that stack that can deliver the surgery is the surgeon. If they need a wound examination or even a debridement of a wound, advanced practitioner can do that. And then we know what nurses do. Everything that's non-clinical is driven down to the care guide, this extra person that we're adding to the team. And then information, particularly clinical relevant information, goes up the stack.